Hello everyone, I'm Richard Conway from Dublin, Ireland, reporting for Room Now from ACR 2023. I'm here to talk to you today about Abstract 1584. This was presented at Monday's plenary session number 2. It was by Ariel Mandel et al., and it was looking at trimethoprim sulfamethoxazole prophylaxis on infections during treatment of granulomatosis or polyangiitis with rituximab. So trimethoprim sulfamethoxazole, Septrin or Bactrim, depending on where you work. We know that it's a very effective treatment at preventing pneumocystis jirovecii pneumonia, which is a horrendous complication that we see in patients treated with our immunosuppressive agents with a high mortality rate. So definitely something we do not want to happen. We also know that patients with GPA are, as a disease, more prone to pneumocystis. It's one of our diseases where it seems to happen more commonly than others. And we know that giving patients rituximab and giving patients high-dose steroids, both of which are often given to these patients, are also strong risk factors for developing PJP. So these authors looked at GPA patients in the MarketScan database. They had 919 patients enrolled, and they were looking at prescription practices around the time of rituximab initiation, so starting on rituximab for the first time. And the really shocking data from this study for me was that only 31% of these GPA patients starting rituximab were on prophylaxis with trimethoprim sulfamethoxazole, and only 40% of those who were on rituximab and 20 milligrams or more of prednisolone were on prophylaxis. And this is a no-brainer to me. Like, these patients should all be on this drug to prevent this potentially horrendous complication. And I don't understand why they're not, but it seems we've got a lot of work to do in optimizing that aspect of their care. The authors went on and looked at some other outcomes. They did a multivariate analysis, and this was seeing if the prescription of trimethoprim sulfamethoxazole helped with other things, and it did seem to. So an adjusted hazard ratio of 0.5 for major infections and 0.7 for outpatient infections. Both of these were statistically significant benefits favoring use of prophylaxis. There was an increased rate of adverse events with 29.6 versus 13.4 per 100 patient years. And really, most of these adverse events tend to be relatively minor things. And I think the benefit very much favors using these agents, given the potentially disastrous consequences of pneumocystis. Remember to follow me on Twitter at Richard P.A. Conway, and check out Room Now for all the updates from ACR 2023.